Well, hello, and thank you for joining me today. I've got a very special guest joining us from Chicago, and we're here to talk about a topic that is very close to my heart, but probably closer to his heart in that he's been talking about it for some time now, in a way that he's been trying to change the way we perceive kids are growing and developing. Dr. Kevin Boyd, thank you so much for joining me today.
Thanks, Stephen, for having me on. It's good talking to you again. It's been a while.
Yeah, we got to catch up quickly backstage, but I think the first time I saw your lecture was maybe 2015 in Chicago, and before that there was an article that you wrote on anthropological dentistry that really kind of sparked my thinking on how we really need to be looking at these jaws a bit differently. We're going to dive into some really kind of interesting stuff on how you're practicing today and what parents are seeing in terms of kids that aren't developing the jaws the way they should. But I wanted to kind of go back to you earlier in your story, how you started to look at this whole issue of children and how they're growing and developing. Maybe early in your pediatric dental career, what were the first markers that kind of turned these lights on for you?
It actually started a little bit before even I went to dental school, Stephen. I have always been interested in pediatric nutrition. And at one time, I thought I'd spend 2 years in the Peace Corps helping kids who were undernourished. This was back in the early 1970s. And eventually, I did do a foreign service project in Honduras in Central America, where I, believe it or not, was made part of a post-hurricane relief team. That there's called Hurricane Fifi back in the 70s, and it was remarkable that it was a dentist who was the team leader, and we hiked up into the mountains of Honduras and really were looking for signs of where we could help out with healthier eating. And it's funny because we go up into the mountains and there'd be like donkeys or burros with food on the, carry them up into the villages loaded with Coca-Cola and flour and, all these things to give them empty calories. Also cavities, right? So we got up there and it turned out to be a dental relief team. And our dentist was actually a fourth-year dental student at the University of Detroit. And she's the one who, even though I come from a dental family, she's the one who really got me interested in maybe a career in dentistry, and nutrition would be a good component of it. So that's how it started for me. And then I did a master's in dietetics and nutrition, and I focused on in infant and child nutrition and how it affected their health.
Such an interesting angle in, and just to dive into that a little bit deeper, what were you seeing in terms of how the health of these children were changing with the infiltration of these kind of ultra processed foods from Western society?
Well, there certainly wasn't any overweight yet, and again, this was the mid 1970s and early to mid 1970s, and no, it was but rampant tooth decay. And it wasn't like you would see. It was mainly their front teeth. They called it the Honduran smile because they would go out into the sugarcane fields and they would suck on the sugarcane. And the sugarcane, if you've seen it, it's a stick. So there's lots of fiber there. But it was the fact that they were drinking Coca-Cola. And because there's other places in the world where kids would chew on sugarcane and they wouldn't get cavities because it was fiber, but it was the processed foods, the flours and the starches and the Coca-Cola. So yeah, it was pretty gross actually.
It's fascinating. You mentioned that they didn't have the appearance of pediatric obesity, type 2 diabetes yet, but the teeth were that pre-marker for the onset of these chronic diseases, which we are now flooded in. And this is really the reality that obviously you're experiencing in your practice today, that kids are really suffering from this modern lifestyle and diet that we are raising them on. How would you say that in this time that what you're seeing today in your practice, things have changed? Can you describe to us the kind of general presentation of children that you're seeing walking into your practice today?
Well, my training as a pediatric dentist really prepared me well to put out sugar fires. That's what I call it. Restorative all day long, every day, operating room. And then gradually, I really became more aware of there are other things like malocclusion, which we will talk about later. And so I trained at the University of Iowa that had a very aggressive program in early was 7 or 8. Now, 7 or 8 years old, that's a geriatric patient in my practice now. I'm treating malocclusion as young as 2.5, 3, 4 years old now because it correlates with other systemic issues, mainly respiratory issues and neurological issues that you know, obviously you know a lot about, Steve. So the nature of my practice has changed because I made it a concerted effort with all the decay is that I really want parents to understand, do you know why your child has so much decay? And oh, they were born that way, or oh, it's genetic. Oh, you know, they don't brush well enough. And I say, no. All those things help. Fluoride, sealants, you know, but how about sugar? So I bring up the sugar word. And I would, you know, and I thought, you know, dentistry needs to spend more time with counseling, even though it doesn't pay anything. We get paid for sealants and fluoride and, you know, there's a lot of things that are considered preventive, but they also generate income. Diet counseling doesn't generate any income, but it does reduce tooth decay in your practice. Well, for me, I had added incentive because I would like to spend more time diagnosing, assessing risk of malocclusion in the primary dentition. You know, orthodontists, they say don't even look at them until they're 7 and maybe don't treat them until they're 10 or 11 when they have more permanent teeth. Well, when I became aware that there are possible respiratory challenges associated with malocclusion, it's like I started treating earlier and earlier and earlier, and pretty soon, you know, tooth decay got in the way. And I just like, you know what? I want tooth decay to go away in my practice so I can focus more on this. This is happening more and more in the United States. There are more pediatric dentists who are just thoroughly tired of treating a completely preventable disease and also looking at malocclusion, which is largely preventable. So that's what I've transformed. So the nature of my new patient now are people that are seeking, you know, because I'm just totally comfortable expanding a 3-year-old. And not many people are doing it, but it's growing and growing. And almost everything I do now, there's not much decay in my practice, Stephen. This is what we do. My partner is a general dentist, a partner of 20 years, and she's an excellent pediatric, you know, she's not a pediatric dental specialist, but she does beautiful pediatric dentistry and orthodontics. So I'm very fortunate to have a GP partner that works with me. Janet Panarella, her name is.
You know, it's fascinating to kind of hear how your perspective of viewing, you know, kind of the broader issues coming in through your practice and how it shifted your perspective on how you practice. And what you're kind of saying is that, yeah, there's all these sugar fires, as you call it. I love that term, that you were seeing in children's mouths with cavities, but all you were doing was patching them up. And really the bigger issue that you were able to diagnose was that the dental arches of these children weren't developing properly. And this was a much bigger problem in the physiology of the child, the growing and developing. And that's just a fascinating perspective that I really want to kind of get into. But I thought we'd just quickly dive into that sugar issue before we move on, because you've kind of gone in and you spent a lot of time in that. How would you describe this difficult problem? Sugar is everywhere in society now. Parents are inundated, and they probably even subconsciously don't even know that they're giving kids as much sugar as they are. How would you describe this issue in terms of, you know, how are parents experiencing this problem, and what are some of the, you know, kind of practical ways that you found, you know, to help parents get away from sugar?
Well, first of all, I tried to clarify sugar. Everyone thinks candy and sweetness. And it really what it is, Stephen, and I know you know this, but sometimes people really need to hear this. And I learned it mostly from Robert Lustig. You've perhaps heard of him. And, you know, he and I started on this journey together. We developed for the American Academy of Pediatrics an abstract that we were going to present together like, I don't know, 12, 15 years ago called Sugar and Decay. First the teeth, then the liver. And it isn't so much sweet sugar, but it is damaged carbohydrate. It's you know, carbohydrate in its intrinsic form is always always intrinsically, intimately connected to fiber. And fiber delivers more than just roughage to your, GI tract. Fiber is where all the vitamins and minerals are, and it's time released. Mother Nature, since Homo sapiens, the genus Homo has been around for 2.5 million years. Fiber has been, a crucial part of our evolution. Fiber releases, it's like time released drugs that you take. Fiber is time releases. I will drop off the vitamin B1 at this part of the GI tract. I will drop off the vitamin C, all the trace minerals, the phytochemicals. There's a place where the fiber would release it. And that's how we evolved. Well, we've stripped the fiber and then we try to put it back, but it's damaged. So fiber needs to be attached to carbohydrates. And so that's what we tell. Eat fresh fruits and vegetables, minimally to non-processed foods. And guess what? The sugar, the sucrose that's attached to it, sugar beets, sucrose. Have you ever seen a sugar beet? It's almost all fiber. Have you ever seen a sugar cane? Like I said, it's a stick. So the sugar is not damaging in its natural form when it has its fiber with it, undamaged. So I try to help parents understand that, and that tooth decay would not exist if there weren't frequent, consumption of, free sugars that feed the bacteria, that poop it out onto the teeth and turn it, it's a metaphor that I use. They form extracellular polysaccharides and they stick to the pellicle irreversibly, and a biofilm forms and it's acid at the plaque interface, and enamel plaque interface. That's all technical stuff. All parents need to know is, look, if your kid my kid never gets it. Almost every parent says that. You say, well, let me do a little detective work here. And I let them get off the hook. It's like, look, it's not your fault. There's a conspiracy of the food and beverage industry against parents. So let me show you how to read a food label. And, let me do an analysis for you. And you don't want to guilt parents out because they're already defensive because their kid has cavities and it is diet related always. And mouth breathing is conducive to caries too, which is another point that might lead us into the next part of this.
Absolutely, yeah, and it's a great foundation, isn't it, to kind of just give that perspective on how delicate diet is for parents to navigate today, and then how affected kids are by what they eat and the surroundings, and it really does kind of lead, I think, into the next part of your story, how you progressed onto seeing, well, maybe actually there are other things going on with this diet problem, and kids aren't growing and developing. Their dental arches aren't developing as they should. You mentioned respiratory issues as being one of the kind of main, signal points or warnings that kids aren't developing well. Can you explain for parents what some of the presentations are for a child that isn't growing and developing their dental arch adequately?
Well, and a lot of parents are, I had a mom in yesterday and she had a 2.5-year-old that had like a 15 millimeter overjet. The chin was way back, teeth were crowded. The kid's not even 3 yet. And the mother was being told by everybody that she's way too young. She'll probably maybe get surgery when she's older. There's really nothing you can do about it now. No orthodontist would even give her an appointment. And finally, somebody had seen me talking about this on a webcast like this, and she found me. And it was her instinct that she's totally right. She figured, she didn't know what it was. She couldn't put it in language, but she knew there was something wrong. Well, a lot of times, sometimes parents, especially moms, sorry, but our Y chromosome gets in the way. We don't have the same instinct as women do. And it's mostly moms that bring kids to me. And so many times I'll point something out and they'll literally out loud, I thought so. When I start relating these things, that there's no space between the teeth, that you can put your thumb between the inside of the upper front teeth and the outside of the lower front teeth. That's a big overjet. And the mandible is too far back. That's not going to get better. And most parents just think, in the analogy I like to give them is like nearsightedness. You see so many 3, 4, 5-year-olds that are wearing glasses for myopia, right? Well, would any ophthalmologist or pediatrician in their right mind say, you know what, if you start correcting that now, you'll go through 4 or 5 different prescriptions by the time they need them to drive a car. So why don't you just let it get as bad as it's going to get, like malocclusion, let it get as bad as it's going to get. They don't say that. They say wait till there's more permanent teeth. Well, an ophthalmologist, it's a really good analogy. You can have neurological damage, a child can, if they can't see, and it gets worse. Problems if a kid is moving through nose starting in the primary dentition. So that's kind of what I want to empower parents. What you're seeing, and I pointed out, and this won't get better. And then if I take an x-ray or something, I will do the whole workup of the x-ray and analysis with the parents, putting it in layman's terms. And do they love being respected? They appreciate it so much. And usually they've been told. I get a lot of referrals from otolaryngologists, from pediatricians, from sleep medicine physicians, myofunctional therapists. These are people who are informed. So a lot of my patients now, Stephen, they're not just free-range new patients that just moved here and they need their teeth cleaned. That still happens, but most people come here informed, knowing that the issues are more than just cavities and gum disease, but the shape of the jaw. And I say, the front of the airway is the face, the back of the face is the airway. They're connected, and here's how we do it. So that's
absolutely, and I'm experiencing the same kind of presentation of parents who have this gut feeling that something isn't quite right, and they're looking at their child, and they're not sleeping well, or they're tired in the day, or they're they notice they maybe even don't swallow their food very well, and there's some functional issue there that they're just not dealing with, and there's a gut feeling there. And they are really kind of seeking this solution that looks beyond, just waiting for, as you say, the worst presentation of malocclusion, which is really interesting to compare that to an ophthalmologist, and how and even the connectedness of the maxilla and the upper teeth and the eyes. That's a really good analogy, actually, and we really should be thinking of it in this way.
And it's medically defensible. It's a medically defensible analogy. I won't go into it too much now, but I found, and I've talked with developmental ophthalmologists that work with kids, and they love it that I'm, equating these two things. So I'm glad that resonates with you, Stephen, because you will get a long way. I learned it from an Australian, actually, Simon Wong. Simon Wong.
Awesome.
That. Yep.
Yeah, well, Simon's he's he's an orthodontist in Melbourne, and exactly. And so this idea that we can change the growth trajectory of a child really is quite a powerful piece of information for parents. So I'm really glad that we're kind of opening that door up. I just want to kind of help people to understand what it is that in terms of the physiology that is being affected when parents are noticing these bite issues. So you mentioned, you can fit the thumb between the upper and lower jaw when the kid is together, so the chin too far back, or the palate is too narrow or high. What are some of these signs? And also, so what's happening with the child's respiratory system when the dental arch isn't developing well?
Well, what I do is, and this is, I find people really find this interesting, is if I just do some basic explanations of the way jaws have always been since, anatomically modern humans, that goes back 250,000 years. So how is it, most people didn't survive past the age of 10 up until fairly recently, and that's just putting, the high rate of infant mortality relative to people who didn't live past 40, is it just about 10 years old. If you want to look up something really interesting, it's called the health span, all one word like lifespan, but health span imperative. And watch that. It's about a 6-minute video, and it really explains a lot of how the things we do in early childhood, not just relative to diet and keeping them at a healthy weight and exercise, but sleep and breathing, is that will help increase longevity, life expectancy at birth. But if health span isn't good and you're starting to get chronic diseases at 60, even though the lifespan is 78, that means you got 20 or 30 years of crappy life. So we want that health span to improve so that they stay healthier longer and maybe just get sick or not sick at all and suddenly die at 106. I mean, that's kind of what we're going for. And that means we have to do things like this, like, you know, with the dental diet, that great book of yours that's helped so many people get their kids eating healthier earlier in life. That's setting them up to avoid cardiovascular disease and cancers and things like that. Well, also, if we can get a kid as early in life, say before the age of 6, we like to say before they're 6 years old, to breathe habitually through the nose, and they're eating healthy, they're sleeping better, they are going to avoid all these things that will not only decrease their lifespan, but decrease their health span. And this is why we are really spending so much more time on this. A new study just came out from the American Heart Association that uncorrected sleep apnea in children will predispose them to hypertension, cardiovascular disease in their late childhood, early adolescence. Well, are you kidding? That's not setting them up for a crappy quality and quantity of life. So I don't know. I just take this very seriously. Our ancestors, even though they didn't, you know, live much past 10, there was a lot of infant mortality. But if a kid didn't have a perfect jaw, Stephen, that was conducive to nose breathing, they did not survive childhood. Impossible. So if you find a skull that of a 40-year-old that died, you know, maybe 1,000 years ago, you know 100% that he had perfect jaws, perfect airway when he was 2, 3, 4, and 5, or he wouldn't have survived childhood to live to be 40. Those are all things that, you know, we didn't learn this in dental school. They don't teach us anything about how to think about evolution and how to think about our genome. All those things, and parents really appreciate it. They really love it. It's usually the first time they've heard it too. So that's really how I try to set it up.
Yeah, I love the idea that we kind of root things into our ancestry and try to think about what, you know, the human lineages have been doing for thousands upon thousands of years, because that pushes us to something that we know is tried and tested. And the messages that you're kind of alluding to in the anthropological studies and texts and records that they pull up is that our jaws are shrinking. Now, there was some really interesting work that you did with Dr. Mariana Evans on the pediatric jaw development. And so you actually noticed this in younger skulls. Can you let us know what is happening in terms of the trends of newborn jaws and the size and how kids have been born with these retrognathic mandibles?
Well, see, that's funny because really the control group are the anthropological specimens. They're the pre-industrial specimens. So, you know, I now, as part of my orthodontic workup, I asked the parents, the mom, if you would please look for the mid-gestational ultrasound between 18 and 22 weeks, because almost every child born in a hospital today they get a 18 to 22 week ultrasound to look for retrognathia. And if there's an angle, it's called the inferior facial angle. And we're actually proposing a trial in the orthodontic department at Tufts University that the hypothesis is if you see retrognathia at 20 weeks, that it's reliably going to be present postnatally or a comorbidity with sleep in early childhood sleep breathing disorders and class 2 malocclusion later on when they become, you know, older and it becomes treatable. So it's a hypothesis that we're looking at. But the fetuses that we have, the stillbirths from 500 years ago, guess what, Stephen? Their jaws are perfect. It looks like I've treated them. All right. So something happened in the last 500 years, 300 years, that this is starting in utero. You see I mean, if you start collecting ultrasounds of your orthodontic patients, you'll see retrognathia, and so much that in orthodontic textbooks, it's being called normal, that it somehow facilitates normal, meaning optimal, but normal means average, and it is normal, just like overweight's normal now. But it's not optimal for health. Is that the conjecture of one orthodontist who's, you know, he's deceased now, but very famous academic orthodontist, said that If a chin in utero is retrognathic, it facilitates negotiation of the birth canal. That is nonsense. It is totally not true. The chin goes nowhere near the pelvis when a child is being born. Functional MRIs show this. It just doesn't happen. No, retrognathia in utero seems to be, just based on the small sample of pre-industrial fetuses that Mariana and I have looked at the Penn Museum, it's a new phenomenon. And we really just don't see it. If I've got a 300, 400-year-old skull of a child who was born at, or died at 2 years old of an infection or something, their jaws were perfect, or they wouldn't have lasted till 2 years old. And who knew that? We've only recently come upon, oh my God, this must be what it is. And we've been at it for over 8 years now, Mariana and I have at the University of Pennsylvania.
And there's no question when we look at the the broader anthropological evidence that malocclusion pops up very, very quickly in the record, and that this is a very, very modern phenomena. So it makes sense it has to start somewhere. And so it seems like you guys have really kind of pinpointed as to potentially right when the critical time space is happening. And so this whole message that I feel that we're kind of we're gravitating around here is that we need to look earlier and earlier and earlier, both into our history, but also into the development of our kids, and considering how our behavior, our environment is affecting the growth and development of our children. Now, you said that you are now screening and treating patients much earlier.
Yes.
Can you just help us to understand what are some of the key the key milestones that the pediatric growth dental arch goes through when the kids' teeth are coming through, and how you are spotting these malocclusions and treating them? What are some of the big signposts we should be looking at?
Well, we're evaluating children's, and we don't say craniofacial anymore. We say craniofacial respiratory, because those are complexes that are intimately connected. You cannot separate them. Whatever you do to the craniofacial complex will affect the respiratory complex. They are intimately connected. Never forget that. And that's really what I try to get through to people. So we first look at the transverse dimension, the width of the upper arch, okay? And if that isn't by 4 years old, at the upper second primary molars, at the front cusp, the mesiolingual cusp, at the gingival margin, and I'm sorry, I'm using dental words, but you can translate them. And you can do this yourself. You just get a cheap caliper at a hardware store for $3, and you measure that distance across the roof of the mouth from mesiolingual cusp to mesiolingual cusp of the upper second primary molars. It should be 24 millimeters plus their age. We call that the Bogue index. Edward Augustus Bogue, B-O-G-U-E, was a physician dentist from the late 1800s to the early 1900s that measured thousands, perhaps tens of thousands of children. He did orthodontics only on kids under 6 years old. And he did it for the purposes of improving their nasal-respiratory competence. He's got loads of publications in the Journal of the American Medical Association, the Journal of Dental Research, which used to be called the Dental Cosmos. And I can send you these publications and references. I'm actually citing them in articles and textbook chapters I'm writing now. 100 years old. Observational studies. They're not random controlled trials. Big deal. There were no random controlled trials back then. It was observational studies. That's all we had. And they did a lot of good. So that's the first thing. I look at the transverse dimension. Then I look at the sagittal dimension. Visually, is the chin too far back? Guess what? It's not going to come forward. A class 2 primary molar, or a distal step, right? Sam Bishara, who taught me orthodontic and growth and development and cephalometrics in the 80s at the University of Iowa, wrote a paper. It's classic. Once a distal step, always a class 2 for the rest of your life, 100% of the time. Class 2 malocclusion in the primary dentition will never self-correct. Impossible. Unless the kid moves to sub-Saharan Africa and becomes a hunter-gatherer. It's just not going to happen. So we treat them. So we look at, first transverse width, then sagittal, which is length. And the maxilla can be retrognathic too, even without an anterior crossbite. Sometimes the mandible is so far back that the maxilla can be back, but not in an underbite. Nobody recognizes it. In order to get the mandible to where it belongs is out here, you have to first do this. And I learned that from John and Mike Mew and Bill Hang, orthotropics. And another measurement for sagittal, or measuring the anterior position of the maxilla from the tip of the nose to the incisal edge of the front tooth, about 22 millimeters plus the kid's age. It's an index. It's not diagnostic, but it really correlates with other indices for maxillary position. So that's the second. And then vertical, you're looking for excessive overbites or anterior open bites. Kids with big adenoids, they get a long face. They call it adenoid face or long face. And that can be, clockwise direction on a Seth. We can fix that. We can prevent it. We can reverse it if you get in early.
Okay, I'm just going to translate some of that because it is some really critical points that I think parents can just be a little bit aware of. And so what you're describing is measuring the space of the roof of the mouth. And so the space you're describing is the inside tip of or cusp of the back kid's molar, so the second kid's molar. And so what you're saying is that distance should be 24 millimeters plus their age.
But you don't do it at the cusp tip. You do it at the gingival margin.
The gingival margin, right? Yeah. So for a mesiolingual through, and you can get a simple little ruler and check your child's palate from the gingival margin and 24 millimeters plus their age. So that's a really easy. Measure. Yeah, and just to get an idea, where your child's at, and then so what you're also describing. So that was the transverse dimension. You're describing the sagittal dimension, which is where the lower jaw sits. So a lot of kids today have their chins further back, and we'll describe how this affects the airway a little bit because there's a good question here. But you're saying that a child with a jaw that sits too far back, it will never correct. And so when that relationship sits it never corrects, and it's not normal to. And you're also saying that the upper jaw can be back as well compared to the lower jaw, and sometimes that all needs to be brought forward. And so you're generally describing that there is a general need to come forward, as Mike Mew and John Mew talk a lot about in orthotropics. And then the other dimension was the vertical. Yes, was the up, where you can get deep bites, so bites that upper teeth that come over the lower teeth. These are pretty simple things to pick up, really. You describe them very technically with your your very profound orthodontic language, but parents can pick this up quite simply, right? And so how do you see that, because someone like you're a very specialized dental practitioner. Do you think this should be, being picked up by pediatricians or, in the broader medical system? How do you think that can help pick this problem up?
Here's one way I found that I can indirectly share this with my medical colleagues, is that if I have a kid with large adenoids, and big tonsils, I don't pick up the phone and call the otolaryngologist. I used to do that. The better thing to do is pick up the phone or write a letter. Dear pediatrician, I'd like to talk to you about our mutual patient relative to breathing. I think maybe a otolaryngology consult might be in order. Or right away, the pediatrician, what? This guy's a dentist. I thought they filled cavities. They had no idea that this is in your wheelhouse. And then you can develop a relationship and together select an otolaryngologist to just do a consultation. It's not a referral to get your tonsils out. It's a consultation. So that's one thing. The American Dental Association, I'm on a task force at the American Dental Association, the Pediatric Airway Health Task Force, and we've developed some screening tools, and we developed a brochure for parents and really professionals, because we didn't learn this in dental school. And it hits all the highlights, but it puts it in very simple layman, terms, which really that's what doctors need, because we didn't get this in dental school or medical school. And parents understand it too. And so that's really empowered this whole movement, because the American Dental Association is solidly behind this now. So that really has been such a big boost. I don't have to really defend myself anymore. I used to. Had a target on my back. Why are you treating so early?
Yeah, it's a change of perspective, isn't it? And all I mean, the other thing too is that there has been so much evidence, in the time, recent times on the systemic and comorbidity risk associated with sleep apnea. And so when we're describing these smaller craniofacial systems, and you're describing it as a craniofacial respiratory system, which makes absolute sense, is that these jaw bones actually are used to breathe, then we should really be thinking about how this is affecting the whole child's development. Kevin, there's some questions here that go a little bit into an area that we haven't touched on yet. It's based on the tongue, and so a lot of parents are dealing with kids that potentially aren't feeding very well, and are being potentially diagnosed with tongue tie issues. But Mo asks, can you explain the role of the tongue in upper airway resistance syndrome, and how do you diagnose the tongue as a cause of UARS? So what she's asking is there a role? We've talked about bones and teeth, but what's the role of the tongue in this whole situation?
Great question. Mo Lynch, I see it up on the screen here. Well, first of all, there's a great article. Is Mo Lynch, is she a therapist or just a mom? Not just a mom, but does a mom with is she got professional?
It sounds like she may be a therapist.
She speaks the language really well.
Yeah, that's
I'm
right.
impressed. Anyway, there's a great article. And anything I mention, like the brochure from the ADA or this article I'm about to discuss, which you may or may not have heard of, is by a speech pathologist from Oregon, the state of Oregon, and a myofunctional therapist. And her name is Linda D'Onofrio, who you should get her on your show if you haven't already. She wrote a brilliant article, and it's really about orofacial myofunctional dysfunction or disorders, OMDs, as really being the basis of all craniorespiratory pathology, non-syndromic. If there isn't a genetic syndrome and your child has a craniofacial respiratory complex that will not optimally accommodate the tongue in an upward forward position at rest and in function, forget it. That's where the tongue is responsible for growing this whole complex. The same way the brain is responsible for growing the cranium, that the eyeball is responsible for growing the eye socket. These are all little sutural connections that have to be developed by function and by pressure and by tension. So that's where the tongue comes in. If your child has any sort of hypoplastic malocclusion, if their jaws are too narrow, too far back, those two in particular, transverse and sagittal deficiency, there's inadequate room for the tongue. And it could have started even before birth. Kids start exercising that whole mechanism. They start chewing and swallowing amniotic fluid when they're in utero. So when they come out, they get on the breast. If a woman can breastfeed, if she can't, they get hopefully human milk out of a cup. And then they start to get baby-led weaning foods by the time they can sit up. All those challenges, that tongue is building a home, building a nest for itself to live in for the rest of its life. That's what the tongue is responsible for. So if a child has UARS and they have any degree of suboptimal development in any dimension of the jaws, then there it is. That's the answer to the question. The tongue, for whatever reason, whether it was tethered, maybe a tongue tie, they weren't getting enough chewing done, there wasn't enough stress to mastication. And the other one, you've heard of the functional matrix theory of growth and development. I just attended a talk, and an anthropologist got up who had studied Moss's functional matrix theory of how stress will actually grow structures. And functional matrix, okay, so it must mean pressure. What was explained was, do you know what the functional matrix is for the nasorespiratory complex is? Air. Air grows it. It pushes it. And if a kid's not breathing through their nose, that matrix won't form. Do you know what the matrix is for the masticatory process? Food, but not Gerber. These kids need to learn how to chew. Kids don't even need teeth anymore. They can gum their juice boxes and vegetable puree pouches. So no, these kids need to have challenges. And the other thing, Stephen, when we were talking about in utero, like, boy, if you see that retrognathia developing, and even micrognathia, which is the transverse dimension that's also going to be picked up on 3D ultrasounds, is that, so what are you going to do? Go into the womb and try to, fix them? Yes, not me though. I'm going to teach the mom, not only with your folic acid and your yoga and all those good things that you're doing, you need to breathe through your nose while you're sleeping, while you're pregnant, because who has priority for oxygen? The fetus or the mom? The mom, because the mom's dead. That's why the flight attendant says, put the mask on yourself first, then help your kid. It's the only substrate that the mother has priority for. All the other vitamins and water, everything else, the baby, the fetus has priority, but not air. There's something called gestational apnea. Google it. Most OB-GYNs don't even know about it. If a mom isn't delivering high quality nasally breathed air during pregnancy, she's going to put that kid at risk, almost like if she was drinking alcohol or doing drugs. It's just not good. Women have to be breathing. And that may mean, Stephen, if you do orthodontics on adults, you may have to expand, or maybe the mom should go on CPAP. There's an Australian OB-GYN who actually puts women at risk on CPAP for, and if the kid's at risk of preterm birth, to keep the child in the womb longer. Colon somebody. I can't remember his name.
I haven't seen that. I'll check that. But I'm really glad you brought that up, because I've just recently my wife's just had our third child, and the breathing issues during pregnancy is real. I'm sleeping next to it, and I remember your paper where you described this idea that, well, if a child is in oxygen deprived situation, we know what happens in altitude where small babies are born, and so there are messages, right, that are epigenetically being sent to the unborn child, and so we know that this is a big issue in our gestational community, and gestational sleep apnea just isn't discussed. So would you say that that CPAP or maybe mandibular advancement splints are an advisable treatment during the third trimester? That makes a lot of sense.
Yeah, I really don't know. I heard about it. Oh my gosh, Sharon Moore. You know Sharon, right? In Australia. She's the one who first told me about it, that there's something going on, that this physician tries to help women breathe better so that the babies will stay in the fetus will stay in the womb longer. Kids who are born, women who have sleep disorder breathing or apnea, gestational apnea, they're at higher risk of developing preterm babies and low birth weight babies from intrauterine growth restriction, they call it. So there just isn't a whole lot discussed about it. So I'm so glad that you are interested in that, Stephen.
And the scan that you and Dr. Evans are looking at, you're looking at right when these tiny little kids, their jaws are growing, they're living inside a living, breathing mother. And so I feel that we're just getting earlier and earlier to the point of, where really the root cause is coming from, or, the contributors. Earlier,
poor women, they have to do everything. It's, something's wrong, it's the mom's fault. How about men taking better care of their sperm before conception? If a guy's drinking and smoking, and who knows, that could be that thing, right? And we get off the hook a lot.
Yeah, and stress too. Stress is a big factor for men, that are taking on young families and work, and really not seeing how that's going to affect their own epigenetic input to a child as well. So that's a great point too. Dr. Boyd, you mentioned Professor Lustig, who's just released a book recently, and his work really is being hammering home the effect of sugar, and in particular fructose, on pediatric fatty liver disease. He also talks about the fatty buildup in the pancreas, which is just so concerning in kids, and how in the studies that they're doing, I think it's at Stanford, that they are actually reducing these the fatty tissues in the pancreas just by reducing fructose. Do you think there's a correlation? We've mentioned upper airway resistance syndrome. So you imagine a child with fatty liver disease and a fatty pancreas. Upper airway resistant syndrome is the early warning signs of sleep apnea. Do you see, these breathing issues as being this spectrum, as where sleep apnea is really the worst end of it, whereas we have this graded syndrome that could be picked up far earlier? If we pick up these kids with before they get the fatty buildup in the pancreas and liver, are there synergies here with sleep apnea and how we can pick up these breathing problems with what you're doing in your clinic?
Well, the insulin resistance that follows, non-alcoholic fatty liver disease, and Lustig and I, we talk a lot. We just wrote a chapter together on oxygen utilization. He's now gotten into the airway issue, and he's, Lustig is becoming very big in dentistry now. He's a hot ticket to get him to speak. But we find that, you've heard of pre-diabetes, right? Pre-diabetes, that's elevated blood sugar, right? And is it going to turn into insulin resistance? And is it going to turn into full-blown type 2 diabetes? We need to recognize it when it's at the pre-diabetic stage. Well, how about pre-apnea? You ever hear that term? Nobody's talking about it. And that's what you're talking about right now. You didn't call it that. But what you're suggesting, and I totally agree with you, is that, yes, OSA is the end stage. It is so advanced. It's like waiting till all the permanent teeth are in, and the malocclusion is as bad as it's going to get. How about pre-malocclusion? I was with James Nestor, you probably know. He wrote the book Breath, and he and I were at an anthropology meeting at UCLA this past weekend together. And one of the speakers talked about, you've heard of a cytokine storm that precedes, Alzheimer's and things like that, and other inflammatory diseases. He said, we have to learn to pick up on the cytokine drizzle. And I raised my hand and I said, how about cytokine overcast in children? Who's talking about pre-Alzheimer's in kids? But there could be things relative to UARS, relative to overweight, all these. We have got to optimize health in children at the earliest possible age, and not in malocclusion is no exception. We can't let it go to its worst scenario, because it does correlate. The malocclusion is a proxy for something going wrong in the craniofacial respiratory apparatus. We don't know what it is yet completely, but we must start to get curious about pre-disease. And so, I'm really glad you brought that up. It's just really important.
I couldn't agree more. And so I think, probably the question on many of the people's listening lips now is, how do we go about, growing these jaws? Some of these techniques, obviously, that you're using are quite, on the forefront. But can you just describe some of the ways that you help a child to grow primate spacing? And just to explain, that's the space between the deciduous or baby teeth, that there should be space in those baby teeth. And so what do you do in terms of the types of appliances to grow orthopedically the pediatric jaw?
I can talk conceptually about that and in principle, but what I don't want to get into, because a lot of people I want to start doing this on Monday. And you just really need to understand that these are not experimental techniques. Maxillary, even if all you do is transverse maxillary expansion, nothing else. Okay, well, before you do that, you must, first of all, do definitive diagnosis. You've got to do those measurements to say, and right, if there's no space between the teeth, that's a sign that there's transverse deficiency. A crossbite, an underbite in the back, on both sides or one, that's almost a blessing, because nobody needs to convince you, the parent, that this is not right and it's going to cause all kinds of problems. So I sort of right away depending on, where I am with that kid, I like to see newborns. And I want to make sure that there's no tethered tissues. I want to make sure the mom baby led weans. So those are things that can be done before you actually get to an appliance level. But let's just say that, okay, I'm seeing this kid for the first time at 3.5, and nobody saw the tongue tie. The kid ate Gerber. Mom worked and couldn't stay home and breastfeed, and the kid sucked on a bottle till they were 2. And the jaw is just, it's obviously transverse deficient, maybe other, dimensions as well, but let's just focus on the width. Okay, well, what we like to do is at the soonest possible time, and there's cultural barriers to this. Like mom wants, I explain how it works and how you can expand. But dad says, no, that's too early. Boyd just wants your money. Wait till they're 13. My grandpa was an orthodontist, and he said that's crazy. So if there's cultural barriers like that, what I say is, until your husband sees this as a component of good parenting, and I'm not going to tell you you're a bad parent if you don't do it. I'm just saying it's in the best short and long-term health interest of his baby that he loves. If I can't give him enough information, then we're just not ready. I won't say I won't treat. I'll just say we're not ready. And you have to do that. Be flexible. The other thing that is really important to understand, Stephen, and I've only recently discovered this, and I found it in the literature, when you expand in the transverse dimension, everybody knows that the roof of the mouth is also the floor of the nasal cavity. So if you widen that, of course you're going to decrease nasal resistance. But guess what else happens when you do this? Who would have known? The nasal pharynx, the throat, where air comes in through the posterior nares, that comes more forward. Who knew that? And that's before X-rays. They knew they were giving nasal respiratory advantage to babies. 3, the ideal time to treat, 2.5. Journal of the American Medical Association, 1922. 30 months of age is the ideal time to treat when there are narrow jaws. They called it deciduous development or maldevelopment or something like that. And distal occlusion was class 2. When you see that, there's going to be respiratory issues. If they're not there already, they're going to be there. If they get their adenoids out, it's going to come back. All right, this has been known for 100 years, Stephen. This whole thing is that sagittal, that throat actually gets bigger where air has to come in through the sinuses. Who would have known that? And we're doing a study now. We've got 50 patients. We're going to be publishing this on kids who started treatment under the age of 6.
A lot of the people listening are based in the US, and if they are, suspecting some of these issues, obviously if they're in Chicago, they'll come and see yourself. But how would you recommend they find a practitioner that is versed in this kind of language that you're talking about?
Well, in Australia, you've got Derek Mahoney, and Derek treats all ages and he does all kinds of things. If you press Derek, hey, Derek, will you treat my 3-year-old? Guess what? He'll do it, and he knows how to do it. But that isn't really how he grows his educational facility and everything, because who's interested in treating 3, 4, and 5-year-olds? They don't go into orthodontics because they want to have screaming brats who won't open their mouth. I'm a pediatric dentist. I love screaming brats who won't open their mouth because I know how to do it. I can get them to do it. I pride myself on it. Any pediatric dentist knows how to do that because we have to fill their cavities. Doing it for orthodontics is easy. If you decided tomorrow that this is all you want to do for the rest of your career, you would develop the expertise in doing this probably in less than 3 months. And because you'd make it your business to do it. I know how you are. You write books and you teach and you travel and come and spend a month with me, and that I just lost. I just lost
Sorry,
it.
just lost you a little bit there. Yeah, well, I can say that this type of practice has absolutely changed the way that we, the last 3 years, it is absolutely, it does change the way you look at, the dental treatment itself. And, the conversations actually with parents, I really agree with that. The parents have to be really ready for it. It's not an easy journey, but once they're kind of on board, it is absolutely it's a journey that they know is benefiting their child long term. There's no kind of there's no convincing people that aren't on board already. So there really is that step that the family has to take on themselves. And I think with pediatric patients, you understand that probably the most, right?
Well, one of the things is really, if it's the last thing you remember that I say, it is so true. Test it out, my friend. Is that there's nothing that gets policy change better than angry mothers, pissed off moms. Like, why is the medical and dental profession ignoring my 3-year-old? And you get enough of them together, get out of the way. And then, they're going to lose, orthodontists will lose market share. Pediatric dentists who don't do orthodontics will lose market share because moms know once they understand it, and sorry, more than dads, we do our best, but we don't have that same instinct. If you can get mothers aligned on the reality, the science of this, that they're relentless when you get numbers of them, and that's kind of what's happening. We have these mommy blogs and things. I'm flooded with. I've had to hire more patient. We need more space, and I'm getting to where if they're 7, they're too old for me. I want to get them before they're 6 years old.
It's an amazing model that you're really pioneering there, and the work you've been doing now, over for decades, looking at how the childhood, growth and development, their diet, their dental arch, how it all pins in together. It's really a beautiful tapestry as to hopefully what will be the future of what pediatric medicine and dentistry is. What do you think can be one of the really big kind of tipping points for the next 5 years to change all of this?
I really don't know. I wish I had the answer to that, Stephen. Data, we need to like I've helped a lot of kids. It's every single day. Parents will say, "Look, can I give you my name? If you have parents that are doubtful of what you're doing, tell them to call me. Look at Mike." And the list is huge of the so. I don't know. It's just getting this data published, but there's loads of data published that shows that rapid expansion is beneficial. And 100 years ago, they were, publication. It's important, but to blame the fact that we haven't published, this has been around for a long time. I think what's really, rather than say what's going to change it, I'm saying one of the biggest obstacles is that the American Orthodontic Association and guys like Kevin O'Brien in England and these key opinion leaders in orthodontics is that, they're not interested in treating 3-year-olds that won't open their mouth. So why should I do that? And when you're providing a valuable service, which orthodontists are, that the public demands, treat my 10, 11, 12-year-old, why should they change? They're making a great living doing something, and there's no random controlled trials that say that if you fix it, if you extend a kid at 4, you're going to improve their life. So, Boyd, show me the random controlled trial. Until then, keep your mouth shut and don't badmouth the orthodontic establishment. I say it's not their fault. Do you know how many courses, at least in America, that orthodontic residents are required to take in pediatric child development and behavior management? 0. How come? Because you will not be treating little kids. They don't need orthodontics. That's the implication. The curriculum in orthodontics is the biggest obstacle to why little kids are being marginalized by the orthodontic profession all over the world. It's just, that's the problem. That's what needs to change.
One of the more hopeful steps forward I heard was that I think it was in France that they were establishing a pediatric orthodontic course at one of the universities there, which really, this is what you're talking about, that there is another speciality here that we really need to carve out in our profession, and that orthodontists, they do their work in the say later or early adolescent ages, but there is this whole other spectrum of opportunity to be able to be treating these issues that do relate to how the health of our children. Dr. Boyd, thank you so much for your time. It's been absolutely enlightening as always, and I look forward to talking and catching up on all of this again. For those that are that would like to visit your practice or follow your work, where can they find you?
You can give them my email, KBO, all lowercase, Kevin Boyd Orange, KBO 569 @gmail. Email me anytime. And Stephen, I just totally appreciate you inviting me on this. You have such a great platform. Your questions were just excellent. I just love talking to you. So great night.
I look forward to how it all progresses, Kevin. Thank you very much, and I look forward to talking soon.
Okay, good